this is Krista Michener. Welcome back to Made to Be Whole. Today we're going to talk to pharmacist Brad White of the Medicine Center in Canton and New Philadelphia, Ohio. He's going to talk to us about compounding pharmacies and a little bit about Low Dose Naltrexone. Stay tuned. Made to Be Whole is intended for informational purposes only. It's not intended to replace the advice or care of a licensed healthcare professional. Participating in this podcast does not constitute a provider-patient relationship with Krista Michener, AHP Integrative Health, or any of the guests featured on Made to Be Whole. Krista Michener, AHP Integrative Health, and any featured guests aren't responsible for any losses, damages, or liabilities that may arise from use of information obtained in this podcast or associated materials. Please consult a healthcare professional for any health-related concerns that you are experiencing. All right, Brad, welcome to the show. Thank you. I met Brad because a patient was the first one who told me about LDN probably 5 or 6 years ago, and I had never heard of it, and I called Brad, and he was really excited to share with me, sent me a bunch of material, and I'll always remember what he said. He said, this is never going to take off or get big because there's no pharmaceutical companies that's going to get rich off of this, and I think he's right. So he's a second-generation pharmacist, co-owner, and vice president of the Medicine Center Pharmacies. He graduated from Purdue in 1996 with a Bachelor of Science in Pharmacy. He's a member of a whole bunch of letters and organizations, and he founded a PCAB accredited non-sterile compounding pharmacy in 2006. So what does that mean, Brad? What's a PCAB accredited non-sterile compounding pharmacy?
Well, what that means is a couple things. All pharmacies in the state of Ohio are inspected regularly by the Ohio State Board of Pharmacy. It's our regulatory agency, much like there's numerous medical agencies that hold practitioners like yourself accountable. But our PCAB accreditation is one that's kind of something we opt for. We don't have to do it, but we do it because it's an extra level of basically helping us be the best version of ourselves, if you will. PCAB is now owned by ACHC. It's the same company that accredits hospitals through JCO and all those special things when you have a facility that has a specific certification. But PCAB, we are inspected and held accountable for both our quality control procedures and the process which we follow. So it's kind of like another form of Big Brother looking over your shoulder to make sure you're doing things right. We send out medications that we compound for independent testing on a regular basis. We have consultants come in and evaluate our processes and our standard operating procedures to make sure that we are at or above the current standard of care. Most of our standards of care right now are set by USP. USP has guidelines related to, here's some numbers for you, but USP 795 is the non-sterile compounding guidelines, which we are held accountable to, and USP 800 deals with hazardous chemicals. So our goal is to provide patients with a high-quality prescription product like you might order for them to help solve a medical problem, but it's also to make sure that we keep our patients not only safe, but our staff members safe while they're preparing these medications.
So if you could explain a little for our listeners what a compounding pharmacy is, because sometimes I'll have a patient and I want to do hormone replacement or LDN, and it takes a lot of talk to help them understand why I'm sending it to you instead of to the Walmart or Rite Aid down the corner from them. What is a compounding pharmacy and how is it different from your regular retail pharmacies?
The best way I think I can easily explain a compounding pharmacy is we have all kinds of tools in our toolkit to help solve a problem a patient has that may not be able to be solved by a commercial manufacturer. So you turn on your TV at night and you see advertisements for all kinds of drugs that you probably can't pronounce because they have all these crazy names now. But all those medications are commercially manufactured by large drug companies. Eli Lilly, Merck, Pfizer. You know, everybody's heard of the COVID vaccine. So Pfizer and Moderna are big commercial manufacturers. The neat thing about what a compounding pharmacy can do is we can provide a custom solution for any provider and patient based on the need the patient has. So for example, maybe a patient has a particular heart condition. Yesterday we had a patient that came to us from a children's hospital. It's a premature baby that has a heart condition. Well, no drug manufacturer in the U.S. makes a strength of a suspension or a tablet for this little baby to maintain their heart condition. So as a result, what we can do is we can work with the doctor to use a chemical for that heart medicine and put it in a suspension for the exact dose that that little baby needs. So we can make custom dosages and custom delivery forms in tablets and capsules, lip balms, lollipops, suspensions, suppositories, all different kinds of dosage forms to help meet a patient's need that can't be commercially made.
And this can also be a big benefit for people who have a lot of sensitivities or allergies. Can you talk a little bit about that?
You bet. And that is a huge thing that we do every day. Patients that are allergic to dyes or fillers. If you ever have taken a capsule, you see maybe a clear capsule with a whole bunch of powder in it. Very rarely does that whole capsule contain just the medication you're taking. Usually it has a little bit of your medication, and then it has fillers to make up the volume in that capsule. And that could be lactose, that could be cornstarch, it could be a number of different inert chemicals or fillers. And many people have sensitivities to gluten or wheat or yeast or dairy or colors. So we can make custom solutions in our compounding pharmacy for patients just like that and remove those allergens so they don't have that problem.
One of my favorite examples is the commercially available progesterone capsules, which are in a peanut oil suspension, like the most allergic thing in America. And that's what I don't know, is that so that they can deter people from taking it? I don't know what the thinking of that is. I have all sorts of theories, but that's a great example. Progesterone, something that you guys can make in a different form that's not highly allergenic. You guys have also done some really interesting things recently as far as pricing and getting away from the insurance-driven model of care. So to clarify, most of the time a compounded medicine's not going to be covered by insurance. Is that true? I mean, I'm sure there are some exceptions, but that's been my general experience.
In general, what we've seen over the last decade is insurance companies have moved from covering custom compounded medication solutions to patients to probably more moving them to that tier where it ends up coming back being a full copay for the patient. So for example, last year, over 78% of the patients we filled compounds for, even if they had insurance, if we sent the claim to the insurance, they returned it at a 100% copay. So the insurance wasn't really doing anything for them. I think it's kind of like this, the way healthcare's gone. They continue to pare back and limit access for patients in different ways. But compounds have always been something that sometimes people need. We are fortunate in Ohio that our Ohio Medicaid plans still cover some compounded solutions for children. The compound I mentioned here earlier in the program that we were making for a cardiac pediatric patient, that was covered by Ohio Medicaid. That's great. We have some commercial plans that are really taking good care of their patients, and they are getting their compounds covered. But for the most part, when you're looking at a solution for patients to be well or to enhance their quality of life, the insurances are just not covering it.
And so you guys have stepped away from the insurance model recently. Can you tell us a little bit about how insurance affects pricing and the way business works and how your model is different now and how that can be a benefit to patients?
Yeah, so January 1st, in our Medicine Center Pharmacy in New Philadelphia, we have pushed the button, if you will. We have stepped away from almost all commercial and Medicare Part D plans. We are still taking Ohio Medicaid managed care plans. But the reality is healthcare in this country has become such a mess, and pharmacy is no different. We're kind of looking down the counter at the patient, and we're being faced with the situation of, are we going to be able to help the patient the way they need to be helped, or are we going to be handcuffed by the system? And the system's handcuffing us, okay? It doesn't make sense to patients. I think the analogies I try to use are, if you were a steel worker that worked in the community, we had a lot of steel workers years ago in the Canton area, and you went to work, you made steel, somebody bought it, you got paid for it, things were great. Well, now the kind of reality in healthcare is with the big pharmacy benefit managers, or PBMs, is the acronym, they kind of dictate price and access. So they tell patients where they can go, they tell patients who they can get their drugs from, and they tell you, the provider, as you're well aware, what drug you can write, which doesn't always meet the need of the patient. So long story short, last year in one of our pharmacies in particular, almost 40% of the prescriptions we dispensed were below the cost of what we got paid to buy the medication. So, patients that look around in the environment, they see doctors not accepting insurances for certain plans anymore. They see hospitals. We have a huge hospital in the Canton area that recently dropped one of the most popular plans in the country. Whenever you see that, all you need to think is that insurance plan is not paying that doctor, that hospital, or that pharmacy for their service. And this isn't about greed. I don't want to come across as being a materialistic pharmacist, but the reality is, if we don't take a stand in pharmacies are going to close across the country. Last year, we have had thousands of pharmacies close across the country. Anybody that had a Rite Aid in your community, they didn't close because they were mismanaged. They closed because the insurance companies are not paying to keep the store and the staff there. So we can dive into that deeper if you want, but we made changes in New Philadelphia because we've moved to a model where we are trying to provide the best value to the patient. Our niches are custom compounded medications. We're the only compounding pharmacy within 3 counties that have been able to provide access to patients, which is great. But we also are providing low-cost generic medications. So many people have seen Mark Cuban on TV talk about cost plus. You've been barraged by GoodRx and Single Care and Help Me Care and whatever the other goofy card names are. But what you don't realize is the Single Cares and the GoodRx cards of the world, they take a chunk out of your prescription every time you buy it. So if you were to come into the pharmacy and use a GoodRx card and you paid $10, GoodRx gets 3 of it. So what we've done is we've cut them out. We've cut Single Care out. We've cut the insurance out. And instead, we're just going to sell you your prescription to you for $5 if you join our membership program. And that way, you get the best deal for your generic. And we are able to pay for our bottle, label, the cap, the drug, and continue to provide patients with a high level of care in our community.
That's awesome. Yeah. I really do think this idea that there is a lot of greed in healthcare, but like you said, they don't understand where the money is going. Most of us are not rolling in it. I did an episode where I broke down okay, here's my hourly rate. Here's all the things that have to come out of that. Here's all the people that get paid. Here's all the regulatory costs. We're trying to keep costs where they are, but still provide good quality care. And when you go somewhere, you have to wonder, if you're paying $2 for something, who's getting paid and who's not getting paid, and where did this stuff come from? Quality control is a big issue. And I know that there's another retail pharmacy around here that has a lot of insurance contracts, but I tell patients all the time, I'm like, unless you have to go there, don't. There's no staffing, there's no customer service. They took on all of these insurance companies, but they don't have people to meet their needs. They don't have people to take care of you, and certainly not to provide that individualized care. So when you talked about compounding, we wanted to dive into LDN, which is low dose naltrexone. So that's an example of what we're using to benefit patients isn't commercially available at the dose that we use. So commercially available, you've got a 50 milligram tablet or injections that are, I think, 300 milligrams around there. So tell us, first of all, what is low dose naltrexone and what are some of its therapeutic benefits potentially?
Low dose naltrexone is an absolutely fascinating medication. And as you commented, naltrexone's been on the market for decades. Naltrexone is a 50 milligram tablet that's been FDA approved for a number of indications, from addiction medicine to that's probably the most common thing. And years ago, for whatever reason, a very insightful physician was looking at his patients in a clinic where they had HIV and they had chronic disease and they were struggling with issues. And for whatever reason, one of the side effects he noticed was they had increased resistance of their autoimmune conditions. They had better feelings. They felt better even though they had some side effects with this drug. So what he did was, what if more isn't always better? We have patients that come into the pharmacy, well, if I take 2 Tylenol, 4's got to be better, right? No, it's not. You need to, talk to your provider or
Right.
pharmacist or read your bottle. More is not always better. So this doctor, Dr. Bahari, said, well, what if we give him a little dose? So he started to give a fraction of that 50 milligram dose to patients and realized they started to have benefits across the board. They had increased mood, increased endorphins, increased autoimmune responses, but they didn't have all the side effects that came with a heavy dose of naltrexone. And, if you've ever taken a 50 milligram tablet and you try to break it down into half a milligram or 1 milligram, you can't break a tablet up like that. So what we're able to do at the compounding pharmacy is we're able to take the bulk chemical of naltrexone and we can customize the dose. I think we make like 35 different doses right now, from 0.25 milligram all the way up to 16 milligrams and everything in between. So the low dose naltrexone has been fascinating because we were fortunate enough to have a doctor who was affiliated with Harvard Medical School at the time think up this thought. And as people started to see results and he shared them around, you have Stanford, you have Penn State, you have Dartmouth, you have all these big-time medical colleges doing research on low-dose naltrexone and how it affects patients with fibromyalgia, how it affects patients with autoimmune conditions, rheumatoid arthritis, Crohn's disease. And for whatever reason, low-dose naltrexone has become one of these medications that literally for hundreds and hundreds of thousands of patients, it's been a wonder drug to give them their life back by helping them deal with their autoimmune condition. So if you have a condition that potentially is resulting in underlying inflammation, you may very well benefit from low-dose naltrexone. That sounds like a snake oil ad, but the reality is
It's
low-dose
amazing.
naltrexone it's cheap,
Yeah.
it's safe, side effect profile is virtually minimal. The biggest challenge that I give you is listening to or the biggest compliment, is that you listen to your patient, you heard what he or she said, you reached out for information, and you were open-minded enough to read some studies and look for more information. I have providers that call, unfortunately, and they're like, why are you telling my patient to take addiction medicine? I'm not telling your patient to take addiction medication. I'm trying to provide you with studies from Stanford,
I was going to say the
Harvard,
research isn't
Penn
hidden
State.
on this.
There's
Yeah.
thousands of articles
Yeah.
to back up low-dose naltrexone.
Yeah.
And, we have all kinds of documents to help you. If you have a question, call us. I've got a little bit of info on our website. We've got some books that are done by the LDN Research Trust, which Linda Elsegood has been an authority in the area for trying to help patients gather information on this medication. I cannot tell you how many phone calls I have been blessed to have with patients where they've told me they've gotten their life back.
Yeah.
And that's why I want to be in pharmacy. I don't want to be in pharmacy to do prior auths and to tell some patient their copay isn't covered or their drug's $700 because the insurance won't let you have the $35 generic. My goal is to help patients solve problems, not to be a middleman for the PBMs buying jets and filling up their ivory towers in other cities. So,
Yay. I'm clapping. It's awesome. Well, if you think about just away from pain, just the whole autoimmune issue, why I think it's such a remarkable and should be first line is I've told someone this week, and I tell them all the time, the reason I hesitate to send any patient to rheumatology is because their answer is to suppress your immune system. Why would you take someone with an autoimmune condition and then suppress their immune system? That makes, yeah, can there be some temporary gains? But what you're looking at with the risk long term, I have one patient who gets her LDN from you, Crohn's disease, had been to Ohio State. They had recommended an ostomy. She was chronically low potassium, like no matter what. We started on LDN and she's symptom free, and like her potassium levels are maintained in a normal range for the first time in years, And so you pay for that. The cost, part of the problem with cost is insurance gets people so divorced from what medicine and healthcare actually costs, because to them it's expensive if they have to pay for it, versus what is the actual cost of something that can literally give you your life back. And when I think of pain patients who literally were having trouble walking, but you push them to the right dose and they're on their feet living life. What is your recommendation? Like, who is the person who you should start at an even lower dose? The standard starting dose is usually 1.5 milligrams and you titrate up. Who are the patients that should consider an even lower dose for starting?
It kind of depends, you know. I think that the neat thing about low dose naltrexone and the curse about low dose naltrexone is there's so many research articles. And to take one step back before I go there, if you don't mind,
Sure.
a bunch of the research articles were all done at 4.5 milligram because Dr. Bahari initially gave patients in his clinics 4.5 milligram. That's great. But the reality is if you, the prescriber, write for 4.5 milligram without titrating up, you have at least a 50% failure rate. When you titrate patients up, whether you start at 0.5 milligram or 1.5 milligram and titrate them up slowly to find their ideal dose, you have at least a 75 to 80% success rate in those patients on average, in my opinion.
That's awesome.
And that's something that I think that many providers, everybody wants that study to kind of cover your liability.
Right.
I get it. And there's a ton of studies out there. But just because you end up at 4.5 milligrams or thereabouts doesn't mean you have to start there. Okay.
Right.
So I wanted to predicate with that. So we see a lot of patients in fibromyalgia that kind of land around 3 to 4.5 milligrams. So, you know, usually what we recommend in the beginning when we were learning about LDN, we'd say start at 1.5 and then go to 2 and then go to 2.5 and then 3 and then maybe end up at 4. But the reality is the best thing the patient can do is take that symptom profile and when you're working with your prescriber and say, okay, today I feel fatigued, my muscles ache, I'm not sleeping well, I just don't have that ability to thrive. You know, whatever your symptom levels are, write that down, date it. And then when you start your LDN, you know, like on a weekly basis, before you would take that next titration up, you want to take that same symptom inventory without looking at the previous one, but then compare them and see, okay, are my symptoms better or not? And interestingly enough, sometimes people will blow through their perfect level just because that prescription says go from 1.5 to 2 to 2.5 to 3 to 4 to whatever. So many times we recommend patients kind of dial it back a dose when they felt better on the previous dose than they do on the higher dose. So that's something to keep in mind. But, you know, for patients on fibromyalgia patients, I'd probably still say you could start at 1.5 milligram and titrate up. Honestly, I feel like more and more I find myself telling prescribers and patients start at 0.5 and then go up in 0.5 milligram increments and see. We're having more and more patients kind of fall between 3 and 4 milligrams. If they've got a fibromyalgia, if they have a rheumatoid arthritis, if they have some Crohn's. But then you've got some patients if they've got multiple things going on. So if you have a fibro patient with Crohn's or a fibro patient with chronic stress, sometimes they're 4, 4.5, maybe even 5.
Right.
So I think it's all depending on the individual. One of the questions that unfortunately has been a common ask on our side at the pharmacy has been, how many doctors have you seen? How many drugs have you taken? How many specialists have you seen? And it's kind of heartbreaking because I've had patients be like, well, I've been to 7 different doctors. I've been to Mayo Clinic. I've taken 10 different meds and nothing's helped. And for someone like yourself to listen to a patient and give them the opportunity to try LDN, you know, sometimes patients are lucky and they get results in 2 to 4 weeks. Sometimes it takes 6 months. So nothing's perfect in this world. We all want immediate results, but we got to realize that we got to be patient. And sometimes there's so much going on, you've got a lot of baggage to kind of fix. Sure. But I really think that the best thing that any prescriber can do is to start low and titrate up. Whether that's at 0.5 or 1, you know, if you start at 1.5 and you go through the cycle and they end up at 4.5 and have had no benefit, I'd start them over at 0.5 and then slowly go up. And you know what? They might end up in the same spot, but they might get a better result because of that slower titration. It doesn't make a lot of scientific sense, right. But sometimes it's just that ability to kind of lead the body from one step to the next.
One way I've found to help people manage that, because they get overwhelmed with pills and they're worried about cost, so I'm trying to be like, okay, how can we help, is to start out with a liquid, because with a liquid you've got a lot more flexibility with your titration, and then once you hit your sweet spot you can make capsules. But for some patients that might be more cost effective. But you have to look at, I think, what you were saying with time. For some patients, you're talking about years upon years of chronic inflammation. And so dialing that back, there aren't quick fixes, and you've got to be looking at whole health too, but just the fact that we can help someone get out of that cycle. One question I have that comes up commonly is how you suggest patients addressing this if they're on narcotics or want to get off narcotics, how we do that titration change, what's safe as far as hours apart from dosing, etc.
Yeah, that's a good question. So as far as let's talk about, we see a lot of arthritis, pain, and inflammation, and patients are on non-steroidal anti-inflammatories. So usually with patients that are taking those, I recommend that they go ahead and take LDN alongside, and then as they feel improvement, they can test the waters working with their prescriber to dial back their anti-inflammatory or their non-steroidal dose. That's the easy one. With different narcotic pain medications, we have to be a little more careful. There's a couple different ways to do it. Generally, LDN, if it's dosed once a day, is done in the evening, and that can be a benefit for patients taking pain pills. If they need to take a narcotic through the day, they could take their low dose naltrexone in the evening when they go to bed. Say they go to bed at 9 or 10 o'clock at night. It's going to be pretty much out of their system in about 6, maybe 7 hours max. So if they need to take a narcotic pain pill at 8 o'clock the next morning or 9 o'clock the next morning, they could still do that. You don't want to take them concurrently because you're kind of negate the effect. But there's also another subset of low-dose naltrexone, which is like ultra-low-dose naltrexone, where you can get into microdosing, and patients on narcotic pain medicines could still benefit from microdosing of naltrexone. And that's a little more complex. It's kind of patient-specific. But the reality is you don't want to give LDN at the same exact time you're dosing a narcotic pain medication. But patients can coexist on both as long as they're separating their dosage by 8 to 12 hours. Some patients find that once you get that chronic inflammation down, as we've already touched on, you don't need as much of the narcotic pain medication. I have patients that have gone to twice-a-day dosing on LDN because they get that, maybe they've got some depression or some different mental health conditions that are benefited by twice-a-day dosing, so you maintain that blood level all day long. So as you kind of dig deeper and deeper into how LDN is being used, you can work with other medications. We have I'm kind of all over the place.
You're
sorry,
fine.
but we have patients on the biosimilars. You hear of Humiras and some of these drugs to help patients with chronic arthritis. You can take LDN with that too. Some patients have gotten combined benefit from taking both. Some patients have been able to take lower doses of their Humiras. But there's a lot of different things. I think the most important thing is that you do a good job communicating with your prescriber, you do a good job communicating with your pharmacy if you need to, and you make sure that you're following your dosing schedules, you're not skipping doses, and you've already kind of touched on it's kind of a whole body journey. There's no quick fixes. You've got to want it, but you've got to look at some things too: diet, exercise, sleep schedule, stress levels, yoga, meditation, prayer. There's so many things that can kind of help you manage all these body systems. Not saying it's easy,
No.
but all these tools really can help.
Well, and I think one thing that patients miss when they look at side effects, and I tell people this all the time, when you're looking at a side effect for naltrexone and you go to the regular literature, you're looking at these higher doses. That's what that's based on, because those are the doses that were studied. So having some willingness and trust to try something different and know that, yes, that's what happened to someone who's taking 50 milligrams and withdrawing from alcohol, but let's start, like you said, with a half milligram or a milligram and see if we can't improve your quality of life, because that's ultimately what it's all about. You mentioned LDN Research Trust, and then obviously they can call you at the Medicine Center, or if they live elsewhere, you can find a compounding pharmacist. Are there any other resources you would recommend for patients who have questions about LDN?
I think so. There's like the LDN Research Trust has links to a number of different articles and programs. They have a conference each year where they invite prescribers and practitioners from all over the world So it's a wonderful collection of case studies and knowledge. So I would suggest that probably be a good destination. Like you said, you can call us at the pharmacy. We could try to help you. We've got a number of different articles that we can help provide education and background with. I think as we continue to move on in this movement, the more people that we can get educated and aware, it kind of raises the knowledge level across the board, and that helps more providers be aware. But Linda Elsegood's written 3 books. There's a 4th one out now, just pretty soon here, where it combines, like, I have one behind me and I don't want to get up from the screen, but she's got an LDN book that's broke down in each chapter is a different condition. Okay. So one is arthritis, one's Crohn's disease, one's fibromyalgia. They've got different pain, cancer treatments and things. So it's very approachable. Right. You don't have to have a PhD to read some of these books, okay? And I think it's when you can help a patient, when I can provide a patient with a book and they can read it in plain language, and they can get excited about it without worrying about a whole bunch of big words and studies, I think that's really encouraging.
Right. And to let people know that even though it's scary that your whole health team and environment may not have all the answers that you were hoping, that you really can advocate for yourself and become educated. And with what you're doing and looking for other independent providers, there's a lot more control that patients can have over their health than they realize. Now, you are Medicine Center is licensed just in Ohio, I assume? Or
we are licensed in Ohio.
Okay.
So, anywhere in Ohio we can help somebody. Okay. As we continue to grow, maybe we branch out, but we're focusing on hometown here right now.
And you mail to patients who aren't local to you, correct?
We can mail to patients in Ohio, okay. Not a problem.
Great.
Yep.
And then we'll put in the show notes your website, because I know that you also have a podcast. You want to tell us about that?
Yeah, my dad and I have done a podcast variety for about 10 years. It's a little different than yours. Mm-hmm. I like your format a lot. We have had a local hospital sponsor us, and they provide us with some physicians that, so each month we'll talk about a topic that's probably relevant. In October we'll talk about breast cancer awareness. Sure. In, this month we're going to talk about when to use the urgent care and when to go to the ER and that kind of thing. So it's a different kind of it's more of a public service announcement. I'd really like to get it more to a format like you have today, where we could engage and talk with people in the community that are making a difference. I appreciate what you've done here today with me and sharing our message. And I appreciate your practice and how forward thinking you all are. And there's so many patients we've talked to that have benefited from your care. And it's encouraging to know that there's providers that are looking for solutions for patients outside of the standard box, if you will.
Well, and it's a real blessing to have community partners, because nobody knows everything. I tell people all the time, if you find someone who knows everything, run, because they don't exist. They don't exist. And so to be able to
There's so much.
Yeah, but to have these kind of coalitions, and at least with technology, even people who aren't super close, we can reach out and share. Now, with your closing out with your membership program, is that something people pay to buy into to do the $5 generics? How are you working that for patients?
Yeah, we do have a membership program. It's $5 a month or $60 a year, and you basically get cost plus generics. So what that means is whatever I buy the drug at, we charge you that price plus a small dispensing fee to cover the vial, the overhead, and the label and that stuff. So, we have a price checker on our website. So if you wanted to go to our website, you could click on our services and the price checker, and you could see what a 90-day supply of lisinopril 20 milligram costs. Sure. It's like $5 or something like that.
Well, and longer supplies are cost effective for patients, correct? Just because labor is expensive.
It is. You wouldn't believe it, but the national average, according to one of our trade industries, it costs like $12 to fill a prescription.
Okay.
But part of that cost is our friendly local pharmacy benefit managers, where you've got every time we send a prescription claim to the insurance, much like when you swipe a Visa card, they charge us a quarter. And if there's fees upon fees upon fees. Right. So, they add to the overhead of the patient. Sure. It's really frustrating.
Sure.
And that's another reason why we've kind of gone to the generic model, because we can cut out all that garbage. You don't have to wait on prior auths. You can get a 90-day supply of your regular medicine. You don't have to wait for it in the mail. You don't have to go down to the big chain pharmacy and wait for 3 days for them to fill it.
And go back 3
We're
times.
hoping we can
and
save
all of
time
that.
and
Yeah.
yeah.
Well, and customer service, having someone who actually is willing to talk to you and answer your call versus just read you what's on the form because you can read,
Yeah.
So it's really nice to have that personal touch and really, check into, even if you have insurance, self-pay for meds is sometimes cheaper. It's sometimes the way to go. And customer service is a big deal. And you can even, I remember the first time someone asked me for more than a 3-month supply. I'm like, what? Because I was in my insurance mode, but you can
Yeah.
buy 6 months at a time and not have to be running back to the pharmacy all the time if you're paying yourself. So if you travel a lot, that can be helpful.
You said something really important, if you don't mind, I'd like to
Sure.
touch on quick. We had a patient on a very well-known national Medicare Part D plan in December. When we switched over in January, we try to have what we call a health coach. So we'll set patients up so that we will call them a week before they need their meds. We'll make sure they're all filled up and ready so that we either arrange a pickup on the day they need it, so we have everything in stock and done, or we can mail it like you suggested earlier, or we can home deliver in our immediate area in the new Philly area. But this patient, we'd filled her scripts and they were due to be picked up in January. Her copays on her Medicare Part D plan were $60 a month more than on our membership program. So, I mean, that's like $700 a year
Yeah.
she was going to pay more
For one medication, and she's probably on more than
I'm
one.
like thinking, come on. So it's just don't assume your copay's the best price is really where I was
Right.
going. And you already hit it. So
Awesome. Thank you so much, Brad. We will put in our show notes links to Brad's website, all the good things he's doing. If you're in Ohio, call the Medicine Center. They're fantastic. And remember to have hope because you were made to be whole. Have a podcast question or suggestion? Text or call us on the podcast info line at 330-439-0686. Thank you for spending time with me today. If you like what you hear, please subscribe to be notified when new episodes release. And remember, you were made to be whole.